On behalf of the South Texas Geriatric Education Center at the Health Science Center and the Geriatric Research Education and Clinical Center at the VA, I wanted to welcome you all here and basically let you know that this course, this 3-day course, has been a process that's taken a couple of years to put together, and we are extremely fortunate to have Dr. Carmel Dyer and her team, and they're going to explain what team is, here from Houston to work with you over the next 3 days. I think that it's a very exciting opportunity for all of us. You are sitting in a brand new administration building, and you will be working tomorrow, part of the day at least, in the Clinical Skills Center, which is a new $5 million laboratory here, and you'll be working with some patients. And that's all been sort of set up and worked on, and I wanted to thank Jennifer Brackett, who's standing in the back. Many of you have talked with her on the phone, who set up this program with Barbara Riley from Houston. Sitting up here in the front, she's going to be talking to you in a moment. And Susan Statmiller in the corner, who's also one of our Geriatric Education Center faculty, and Mark Johnson, our computer and film guru, up here in the front. And everyone has really contributed, worked hard on this. I think it's going to be a very rewarding experience for everyone. There were a number of people who desperately wanted to come to this and couldn't because of work responsibilities. And so I think this group here is extremely fortunate because you're a good sized group to work with. You'll get more out of it. Feel free to ask questions as you go along, unless someone tells you that they need to not be interrupted for a certain period of time. And actually, Barbara Riley, Dr. Riley, is going to be introducing everyone who came from Houston, and I'm going to give you a brief intro and also let you know that that is in your blue folder. You have the full long write-up on everyone, and as you can read here, oh, it even tells you what team is. There's no surprise. Team Elder Abuse and Mistreatment Institute, and that's team, and she is the administrative coordinator of that team at Baylor. And of course, it's also part of the hospital district in Harris County. She's got over 45 years of experience in nursing, administration, and education, and has been instrumental in developing numerous national conferences and workshops. In 2005, she made over 50 presentations on elder mistreatment. And you'll find out as you go along that this group has all really made tremendous strides in this area and done a lot of education. She was formerly the Chief of Program Development Evaluation for the Cancer Division of the CDC in Atlanta, now the CDCP, and she served as scientific co-chair for 2 national cancer conferences. She has several publications, manuals, a book to her credit, and has received numerous awards and honors for her work at CDC and her work with Cambodian refugees in Thailand. So that makes it very wonderful to have her come and do the moderating as well for her team. And the packets that you have in front of you, Dr. Dyer has gotten a grant from the United States Department of Justice to put this program together, as well as from the Geriatric Education Center Network. And we're just thrilled to death that everyone's here. So Barbara, why don't you take over and do the moderating?
I'll use the microphone. Sometimes my voice kind of gives out, especially with all the cedar you have here in San Antonio. My name's Barbara. As she told you, I am a recovering conference coordinator. Actually, I have one more conference to do, and then I'm going into rehab. And I'm going into rehab for the rest of my life. If you will refer to your folder, I want to go over a few things. Now, given the number of years I've been working and my age, you can forgive me if I've forgotten a few things. We never lose our ability to process, but sometimes we get a little slower. You have, first thing I want to ask about who all's here. Because, well, I think we have a very eclectic group, probably one of the most eclectic groups we've ever had. How many nurses? All right. All right. Let's hear for nurses. How many social workers do we have? All right. How many adult protective services caseworkers and supervisors do we have? One right there. And I think that more are coming later today and tomorrow. Any other psychologists?
Physicians too. Psychology, yay.
Yay. Fellows, physicians. All right, good. So we have dentists. Oh my gosh, I forgot. And attorneys. Yeah. Wow, we have quite a group here. So welcome to everyone. Please feel free to talk to one another and to network. That's always the best. We find ways to working together. Your agenda, there's some slight changes in your agenda. If you will go to page 2. No, I'm sorry. It's on page 1. Dr. Carmel Dyer, her talk for 12:45 has been moved to 2 o'clock, and Sabrina Pickens' talk is going to be at 12:45. So if you'll make that adjustment to your agenda. Dr. Dyer is moving till 2 p.m. and Sabrina is moving up to 12:45. Also, a couple of things I failed to put in the packet. Jennifer Brackett, oh, she's a wonder. And she has a new baby, but she kept sending me stuff and saying, this goes in the packets. Well, of course, I forgot 2 of the things. So later this afternoon for the physicians, we are going to be bringing you a CME statement of attendance. And also, each of you in this room need to fill out a participant profile. That will be added to your packets also this afternoon. On the left-hand side of your agenda, of your packets, you have the general instructions for the pre and post test. And what you've done, you'll notice there's some handwriting on the pre and post test. In that first column, we want you to put the pre-test answer. In the second, where it says post-test, we want you to put your post-test answer. So is that clear? If not, I can go over it again. Okay, I think we're okay on that. And you know, if you have other you know, if you get mixed up during the day, it doesn't matter. We're here. Sorry about my voice. I don't know. I think it sounds like you all don't remember, but there used to be this actress. Her name was Veronica Lake, and she wore her hair. She had long blonde hair. She wore it over her eyes, and she talked like I'm talking now, and it was considered very sexy. So you just think of Veronica Lake. I'm gonna I'm going to be introducing our speakers now, and we have a wonderful team. I want to thank Michelle and her group for allowing us this opportunity. We are always enjoy coming and talking to folks about what we do. We are down in the trenches so far that we just are open to everything. We're very, very anxious to hear anything that you have to say, your opinions, your questions, your thoughts, your insights that maybe could help us as we move forward with our efforts. The first person I want to introduce is Dr. Carmel Dyer. She is going to be speaking. Oh, I forgot the housekeeping. Please turn your cell phones off. The restrooms are out the hallway to the right, and there's water, juices, Cokes, food over here on the table, so help yourselves. If you get kind of restless, feel free to get up and walk around, stand at the back of the room if you want to do that. I'm going to first introduce Dr. Carmel Dyer, who is going to be speaking about the medical implications of elder abuse. Dr. Dyer is a phenom. She is nationally known for her work with the elderly. She is particularly interested in helping those people who are abused, neglected, and exploited. She is the director for the Baylor College of Medicine Geriatrics program at the Harris County Hospital District. 10 years ago, she started with one room about the quarter the size of this room, and now we've taken over 2 floors of the hospital. And we're planning on taking over the whole facility in the next few years. She is the founder and co-director of the Texas Elder Abuse and Mistreatment Institute. It is the first and probably the only program of its kind in the nation. There are some that are almost like what we do, a little bit different in their focus, but we have grown over the years. Our mission is to improve the lives of mistreated and abused elders through clinical care, education, and research, and that is Dr. Dyer's dream, and her dream will come through too. She is the principal investigator on a large National Institutes of Health grant called the Consortium for Elder Self-Neglect of Texas. We started out with a few investigators. Now I think we have 26 investigators, scientific investigators in our consortium, where we do research, groundbreaking, new, innovative research in elder self-neglect. Dr. Dyer is testified twice before the United States Senate, once last week on the effects of Hurricane Katrina on older people. She has too many publications and too many presentations and books to recite. It would take all day. And she's often sought after. In fact, we haven't seen much of her in the last few weeks. But without further ado, I want to introduce Dr. Carmel Dyer.
Take this on. Thank you, Barbara. That sounded like my mother wrote it. Appreciate it. Morning, everybody. Very excited that you all are here, and the mix in the audience, I think, is tremendous, because we really believe that you can't do this work in a silo. You can't. In geriatrics, we have this motto: 1 = 0, and so it really is important to have all of you here. You know, our work reads a little bit like a public health novel. We were this geriatric team at the public hospital, and we wanted to come and help people. We had nurses and social workers and physicians working with us, therapists, etc. And we had developed a house call team. We had inpatient units, outpatient clinic, and Adult Protective Services came to us and they said, look, would you make house calls on our patients for us? We need somebody to go out because sometimes the clients won't leave the house. And we said, sure. And we had this vision that we would be, sitting in the parlor, sipping tea and helping adjust people's medications. And what we saw when we went to these homes was very different. We saw uncared animals. We saw patients living in absolute squalor. We saw people who were financially abused, people who thought they were living in their own house, but actually it now belonged to somebody else. And so we began to ask why. And we started just really a clinical team. And our work, you think of an academic center, we're not sitting in some basement, of course now we are, but we were sitting in some basement just thinking about the problem. We got out and we have served over 1,000 people who have been abused or neglected or exploited in some form. And so I'm so happy that our team is here to share the experiences with you. All right. So we should go to my talk. So this module is to set the stage for what's to come. Come on in, everybody. Welcome. We're happy you're here. All right. The objectives for today are going to be, for me, this hour is to describe the prevalence of abuse in this state, across the U.S., the types, the importance of elder abuse, and the ethical obligations of clinicians, or everybody, to society. And so, let us begin. This is what they call adult learning, interactive. It's actually testing, but if you would turn to your sheets and answer the following questions. What is the prevalence of elder abuse among the United States senior citizens? Is it 1 to 5, 5 to 10, 10 to 15, 15 to 20, 20 to 25%? Sign a little paper. This is how CME is done. You know, I'm not permitted to tell you the answer. All right, next question. Hopefully you'll find the answers as I speak. But, which of the following describes the mortality for victims of elder mistreatment? Is there a 1-fold increase, 2-fold increase, 3-fold increase, 4-fold increase, or 5-fold increase? Those of you that are physicians in the audience may recognize this is the national board format that where they have you always see, so there's no clues. You know, you're supposed to not give any clues, so you have it in ascending order. Okay? Next question. Which of the following is the most common type of elder mistreatment? Is it physical abuse, sexual abuse, caregiver neglect, self-neglect, or financial exploitation? Okay. Let me begin. Here is the outline of what I'm going to talk about. I'm talking about the types of elder abuse, what we know epidemiologically, and start to describe to you the intervention and what are the types of things that we can do. All right. Physical abuse. I mean, this is the stuff we hear about in the newspapers. Right? Somebody's burned with cigarettes. Somebody is beaten up. This is a willful infliction of injury. And by the way, these are the Texas standard definitions here. When somebody is physically hurt by another person in a fiduciary or trust relationship with them. I've seen so many cases of this. I guess one of the worst ones I saw, I'll never forget, was a 93-year-old woman who was beaten up on Christmas Eve. And I can still see her face. She had a swollen face from being kicked in the face. Her niece was caring for her, by the way. Her niece was 77. Developed a urinary tract infection, became delirious, and when the aunt fell out of bed, she got confused and started kicking her to get her up. So we had to treat both the victim and the perpetrator in that case. Sexual abuse, non-consensual sexual contact of any type. Any type of unwanted touching or frank sexual assault. You know, I heard a presentation about a year ago from a nurse who has done a lot of this work. And she gave 10 clinical descriptions of some of the most horrendous cases I had ever heard. And these were cases where the perpetrators had confessed to the incident. And this is not as common as the others, but this is something that should never happen in the United States. Psychological abuse, the infliction of anguish, pain. People are emotionally abused. You know, I mean, I'm in clinic sometimes, And I wonder, I see family members yelling at each other in the clinic setting. I mean, and you think they can't hold it in even right then and there. And when everybody's listening, I imagine, you know, what's going on at home. If this is how they act when they're around others. Neglect. The failure to provide or provided the goods or services which are necessary to avoid physical harm, mental anguish, or mental illness. And neglect comes in two forms, self-neglect and caregiver neglect, and we're going to discuss all of these today. And exploitation. That's taking something that does not belong to you. I guess one of the worst cases I ever saw of exploitation was a woman who had, her husband was a physician, and they had lived in, like, I don't know, the Caribbean or somewhere. I don't know what he did. He was a neurosurgeon or something, but he was a physician, and he had a son that she raised since he was 2 years old. When he died, told his son, please take care of my wife. So when, after he passed away, he put her in this assisted living in my neighborhood where I live, and told the people there, oh, she's got plenty of money. She'll have enough to... In 18 months, she was evicted and had to go to a Medicaid facility because there was no money left. While at the same time, he had a lovely house. 4,000 square foot house, a couple of SUVs in the front, and he had taken all her money. And that woman had raised, I know it wasn't his mother, but she had raised him since he was 2 years old. Then she was left penniless. Epidemiology. You know, I'm always struck by how much emphasis is put on in health professional school on screening for cancer. I mean, no, cancer is bad. I don't think we should not do it. However, when you think about the relative risk of having cancer versus being mistreated, it's a little different. In the United States in 1996, and the stats, it's a little bit higher now, but they're not much different. 133 new cases of colon cancer a year. Cervical cancer, 66,000 new cases every year. Breast cancer, 185,000 cases a year. And we know that millions of federal dollars go to research and training and education in cancer. And I'm not saying that any of that money should be taken away, but in the United States, there's an estimated 2.1 million cases of elder mistreatment a year. And there have been less than 15 studies on elder mistreatment ever funded by the NIH. And every clinician is taught you have to screen for these things. But none of us are ever taught to screen for elder mistreatment. So we screen for the things that are less common. Well, what's the prevalence? In Boston, Dr. Pillemer did a study where he called up people. That Boston study did not include self-neglect. But he called up people and he said, look, he called up seniors and he said, are you being abused, neglected, or somebody taking your money? 3.2% over the phone admitted that yes, they were. In Connecticut, Dr. Lax did a study looking at what they call their ombudsman program. It's APS, and Adult Protective Services in their state. 7.4% over 11 years were reported. 7.4% of people in this larger database. In the Netherlands, it's 5.4%. Huge numbers. Now, we took a look at the Texas database, and certainly we have, we did a whole analysis in 1997, and Texas is very innovative, and you would think, well, it's a database. I mean, doesn't every state have a database? But no. It's very hard to get a hold of the numbers, because some states have these data by county, some of them have them by program, and so Texas having a centralized database is very innovative. In fact, how many of you are aware of the Elder Justice Act? There is a bill that's in the Senate and the House right now, and you'll be hearing more about it, I'm sure, but basically there is a mandate in there to have a statewide database just to even get a handle on the numbers. Anyway, our database is deep in the heart of Texas in Austin. Now, in that year, there were over 40,000 cases reported, 27,000 were elders, and the prevalence was 1.3%. What we mean by that is we took a look at how many older people there are in Texas and how many were reported. So, that may sound like a small number, except when you realize that in Texas, we have the third largest number of older people in the country. We are number 3. We have over 20 million older people in this state. I think only California and Florida have more elders. That's not really a small number. And as a matter of fact, the National Association of Protective Service Administrators just issued a new study. They published one in 2000 and 2004. And I'd like you to take a guess, what was the percent increase of cases between 2000 and 2004? I'm sorry? 10%? 50%? You must be an APS worker.
Yeah.
Okay? It seems like it. Actually, there was a 20% increase nationally from 2000 to 2004. 20%. Of course, the expenditures increased by 20%. Actually, in that study, it was very interesting. States spend an average of $8 million a year on protective services. I mean, considering a whole state budget, I mean, is that, that's... anyway, the state of Texas budget is closer to $40 million. This was the data back in '97, and again, remember, this is part of a curriculum that we developed back then for the Department of Justice, and so I can update these statistics for you. However, the percentages stayed the same. There's caregiver neglect, there's abuse, including physical and sexual, there's financial abuse, and then there's self-neglect. And self-neglect was the most commonly reported form of elder mistreatment then, and it's the most commonly reported form now, and it's the most commonly reported form in any state or any study that you look at that includes self-neglect. By the way, only about 27% of states mandate reporting of self-neglect, and so I think the numbers are even underestimated, but it is the most common form. And so if you think of it like a pie, physical abuse is a small part of the pie, exploitation is slightly smaller, and neglect, including caregiver and self-neglect, is larger. Now, based on your experiences, would you agree with that? Is that what people are seeing here?
Yes.
You're seeing that. You feel that way. You're from APS, right? Well, you're saying no. What are you seeing? All hidden, yes?
You can't even get them to admit that they've had a little fall or a trip.
Exactly. Exactly. You can't even get to admit that they've had that. So how many people are going to come in and say, I used my mother's money to buy a new, Hummer? You're not going to hear that. The other thing is, the elders, you can understand it's difficult to take care of a wound and you need some training, but money is clear to everybody. And if I don't use my money wisely, my social worker is going to think that I'm demented. She's going to think, or he's going to think that I can't take care of myself. The doctor's going to put me in a nursing home if he hears that I allowed this money to be taken. And by the way, I wasn't a very good parent, and I owe them a little something. And my son tells me that all the time, or my daughter tells me. And so it's very insidious, the financial exploitation. And so my hope is we have a better handle on these numbers in the future. The National Institute on Aging is funding 2 grants to look at the prevalence of all the types of elder mistreatment. So we should have data in about the next 3 years on that. What we do know, and this is true across the country, although here these are the Texas numbers, is that persons of color are reported in higher numbers than whites. Now, nobody thinks that it occurs essentially more frequently. This has to do with sort of an artificial number. We're just counting reports. So we really don't know. It may be, one of my theories is that sometimes the neighborhoods are more closely connected. And somebody might have lived there for 30 years, and so the neighbor says, Mary didn't used to live like that. There's a change. I'm going to report her to Adult Protective Services. It may be that people are more tied into the public health system and say that, the governmental agency should help us. We need a lot more research on this to find out why we're seeing higher reports. But make no mistake, more white people are reported than persons of color in total numbers. Who are the perpetrators? Who's doing this? Well, here are the numbers from the state, and they haven't changed much. Sons, daughters, spouses, grandchildren, other family members. You know, that was hard for me to get a handle on. You know, you think, I mean, people steal from older folks and all that, but elder mistreatment, the true definition, is that it's something that's perpetrated by a person that you have a trust relationship. And I mean, I think this is why nobody wants to look. Who wants to really think that one's child could do this to him or her? I mean, who wants to ponder that? But look at the numbers. And I'm sorry this doesn't come out as clear, but people die as a result of elder mistreatment. People die as a result of elder mistreatment. I mean, I think when I go around the country and I talk about this, people raise their hand and they say, well, you know, so what if somebody wants to pile up their newspapers in their house? Well, so what if they want to live like that, if there's, you know, dirt on the floor? Well, what if they don't feel like eating properly? You know, no, we don't like to eat properly. We don't follow the Mediterranean diet or whatever. But the truth is, what we're talking about here is, we're not talking about mild cases. We're talking about cases so severe that that I think if we brought the politicians just into these homes, that there's no way that they could ignore this issue. It's just so horrendous. And now we know that it kills people. Dr. Lax did a study where he took an established database called the APESI. And what was done is there was a cohort of senior citizens that were enrolled in this database and followed regularly over time. And so they had all these data on them. They knew what medical illnesses they had. They knew whether or not they were abused. They knew what they died from. At least they had death certificate data. And they had their functional status. They had their mental status. And he then crossed this with the Connecticut Ombudsman data, which is their adult protective services. By the way, most of the patients, well, the majority you see were self-neglectors, 180 versus 78 elder mistreatment. But anyway, he took a look at the death records, the death certificates from all these groups. He took a look at a group that were self-neglectors, that were considered elder mistreatment, and that was physical abuse or caregiver neglect. And then he looked at folks that were never reported to Adult Protective Services. And look at the numbers. If you were never reported to Adult Protective Services, and I think the percentages are off on the side here, but basically it was something like 7% or a very small percent of the elder mistreatment patients, but no elder mistreatment died. Whereas, look at the high percentages, 31 of 78 who were mistreated died, and 73 of 180 died. And so this makes the mortality rate due to elder mistreatment threefold that if you've never been reported to Adult Protective Services. Now, when that statistic became public, you know what some researchers said? Well, maybe if you report somebody to Adult Protective Services, that's what's lethal, that it's not the underlying cause. But I can tell you, after helping over 1,000 of these folks, that they are medically sick, they have untreated medical conditions, they're demented, they're depressed, and you'll hear more about their medical conditions. And you know what? Have you ever heard the saying that when people get referred to hospice just like a little too late? They get referred to a hospice and then they die in 3 or 4 days, or they didn't get there soon enough. That's the same with Adult Protective Services. It gets to such a bad level that if only there was increased awareness and these cases were reported sooner, at least it's our contention that the mortality might be decreased. Well, now, why did these persons die? In fact, before we go there, I'd just like to see what you all think. What do you think the major cause of death was? Dehydration was one. Infection or sepsis? Malnutrition? Well, none of those. What'd you say?
The flu.
The flu. I mean, those are all good. That's what I would have said. But however, they died due to circulatory disease. Well, what does that mean? That's some death certificate where everybody dies when their heart stops, and that's circulatory disease. The answer is we don't know, and you may be right. None died due to injury, however. Oh, but that's the death certificate data, and so at least whatever physician was taking care of them and signed the death certificate didn't feel like they died due to injury. The self-neglect patients did have a higher rate of nursing home placement, and they postulated that the possible causes of death were malnutrition, general frailty, or their combination of all their medical illnesses. I can tell you though from our research, and we've looked at 70 self-neglectors anyway, we're not finding protein calorie malnutrition. And I'm shocked because when we started the study, I thought, oh yeah, it's going to be malnutrition. We're finding distinct vitamin deficiencies, however. Vitamin D deficiency, vitamin E deficiency, vitamin B12 deficiency, but they're kind of plump. They had higher BMIs, and so that's interesting. I don't know why victims of elder mistreatment die, but we're gonna attempt to find out. We're submitting a grant to the NIH where we're going to follow people for 5 years and visit them frequently during the year, and then have a medical examiner figure out why they died. Because, I mean, if you're a doctor taking care of somebody elderly and they die in the middle of the night, and you get called to sign a death certificate, you don't know all the circumstances. And so we need more accurate data to give you these answers. Well, what are the risk factors for being mistreated? Well, age, that makes sense. Dependency. When I first started working at Bental, there was a family, a woman who, she was from Britain, and she brought both her parents over from England. And they were a vigorous couple, and they could do everything for themselves. Well, within 1 month, her mother developed pneumonia and became bedridden following a prolonged hospital stay, and her father fractured his hip. And they went from being very independent to being quite dependent on her. And we helped get some temporary placement for one of the parents so she didn't have that high burden of the dependency on them. Oh, and by the way, since they were British citizens, they couldn't access any health services here. She had brought them from England where they had complete health services and health care to here where they had none. Dependency, functional decline, personality disorders. We probably have all taken care of patients or clients that refused care. One bed-bound woman, I've never seen anybody, she fired 5 providers in a matter of a month. And she was bed-bound and couldn't reach a telephone. You're laughing because you see that all the time. Exactly. All right. Isolation. Fewer people that go into the home, more things can happen. One time we went into a home and we started to get into this elder mistreatment business, and we made a house visit. We had taken care of this woman in the hospital, and she had done well, and we were happy. We were just doing a post-hospital checkup when we walked into the house and found her tied in a chair to the curtains to restrain her. They had backed the chair up and they used the curtains for each of her arms. So isolation, not such a good thing. The one thing we do know about intervention is the more people that go into the home, the less opportunity, right? I mean, with any sort of issue like this, we have to decrease opportunities. And obviously the excessive use of drugs or alcohol. The worst scalp laceration I saw was a woman who was 70 years old. She had a 50-year-old boyfriend, and they liked to drink. And one evening, he got upset with her for some reason and hit her over the head with a bottle and beat her. And so she was admitted to the hospital, checked very carefully. She had this sort of, stringy hair. Anyway, a scalp laceration was missed. And our nurse practitioner picked it up and found that it was just pus in a lesion this long. so it took quite a while for her to heal. She was in our skilled nursing unit trying to heal for a long time. But, you know, she was abusing alcohol herself. More victim risk factors. We talked about the studies earlier, but certainly poverty and cognitive impairment are victim risk factors. Everyone here would have guessed that. Now, what are the perpetrator risk factors? Psychiatric disorders, dependence of the abuser on the victim, external stressors, lack of experience, caregiver burnout. One of the first cases of frank physical abuse I saw was of a woman who had a stroke, and her daughter was caring for her. And APS had brought the case to an emergency room physician when the woman had some bruising on her head. And although she didn't have the lesions at the time, they showed the physician, they said, look, they said, this is what her thigh, she was set on a radiator. Where they found a radiator in Houston, I don't know, but I can think some of the old homes have them. And she was discharged from the emergency room with a visit to the hypertension clinic. And so Adult Protective Services got her into a daycare center, but the woman kept coming back with bruises. And the daycare center was worried about her, and they were also worried that, you know, they would be considered the abuser. So we brought her to the hospital, and she cowered in the corner. We were a team of, you know, sometimes when the teams of doctors descend on you, it's a little disconcerting. We were all women, by the way, and she was a woman. And so I said, well, just one of us will go up. And so I must have walked up to her, and she still cowered in the corner. Come to find out that the daughter was the perpetrator. The daughter had a mental illness. And in fact, one time, by mistake, you know, one of the nurses who was not a regular on the unit, she was just brought in that day, let the daughter and the patient go downstairs. She came back with bruises on her arms. And just, you know, she went down to smoke a cigarette or something. And so the daughter was using the mother's check because she was dependent. She had a psychiatric disorder. I don't know what stressor she had. Clearly she lacked experience, and I guess burnout was one way to look at it. And so what we really all hear about today is the intervention. You know, I think that one of the reasons why we haven't been able to at least get the medical profession, physicians really, as engaged as we need to be, is because once you find it, what do you do about it? And so there's a number of things that we can do right off the bat. You provide a supportive environment. I mean, that's a given. Alleviate fears to the extent possible. Involve other available support systems. I mean, there is not going to be, you'll see from this list, there's no one answer. There is not a textbook, and I don't think there'll ever be a textbook that you'll pull out and you go, okay, bruises here and some of the money being stolen, and so here's the line, and you follow this, and you look at the paper and you say, I'm going to do this. They're going to have to be tailored. The other thing is that I think that clinicians sometimes, you can get so caught up in the surroundings, like, you know, how filthy the house was and things, and that we don't forget that we have to do the same things we've always been trained to do. So when you're speaking to your colleagues and you yourself, you get a complete history. And you're going to hear about some of the finer points in how to get that history later. Obviously, review the patient's medical records and closely monitor the patient's reaction during the physical exam, noting signs of anxiety, stress, all good things, all things we were taught. But I think if you stop here, you're going to miss the picture. Actually, Judge Hartle and I worked on a case where there was a woman who was living in the outskirts of a very wealthy section of town north of Houston, the Woodlands. Well, but for her, they were truly woodlands. They were not, you know, the $500,000 homes and the paved sidewalks. This was the woods. And we walked up to the house. The woman was living with the a former employee of her deceased husband. We walked up to the house, and there are the food trays from Meals on Wheels stacked as high as my waist on either side of the door, discarded. There's a large dog barking, and the caregiver was screaming at us through the door. So we go in after a few Hail Marys, and we go to the house, and it's absolutely covered with feces everywhere. The smell, it's July, it just kind of knocks you over. And so we get him to control the dog. We go in to see her, and she's lying in her own feces. She's extremely thin. It takes her 5 minutes to get herself up. Her clothes are urine soaked. She's laying in her own feces, and diapers are thrown in the corner. Used diapers are thrown in the corner. There's a hole in the wall where he got so angry he punched it in. He has been arrested for threatening her with a gun. Okay, imagine that picture. So we remove her. We get her to a hospital where they bathe her, clean her hair, put a fresh gown on her, and feed her. And she looks kind of nice, She's not in the situation we find her. Psychiatrist walks in to see her and she says, "Oh, honey, I'm just fine. I live in the Woodlands. Come on. Well, my house is a little messy, but I'm going to get it cleaned up. I'm an architect," which she was. "And I'm building a shed, and we're going to get that taken care of, no problem." Calls her competent because based on traditional standard medical training, that woman displayed competence. But you can't stop. I mean, the physician took a good history, I'm sure, but you can't stop there because she actually missed the whole picture of what was going on. We tried to inform her. Actually, I hope I haven't taken any one of y'all's cases, what you're going to tell. We tried to inform her. She did not take any advice, and so APS did what they can do, and that is went in there and did a complete cleanup. But they followed up. They followed up within a few months, and the place was back the way it was. And this time, we sent her to a different hospital. But, we had, accurate, and we brought pictures this time, and so it was clear. But I can tell you, in the psychiatrist's defense, it was a little tough. That was a tough case. Because my colleague called me up and said, "Carmel, are you sure that this woman doesn't have capacity?" Because she really was very eloquent. But once I was able to say I was there, I saw. So, I think the history and all of this, it's very important, but there's more to it. Obviously, you need a good physical examination if there's frank signs of abuse and neglect. In the physical examination, you'll hear about these discrete things later in the discussion. Obviously, your suspicion should be raised. House calls are very important, as I just described. I don't mean, not every doctor or nurse can get out there and make a house call, but this is really where Adult Protective Services is a great and valuable resource to us when we're in the clinic setting. I mean, we see nice little happy people for 5 minutes, or in geriatrics a little longer, half an hour, but in our office. But and Sabrina Pickens conducts research in elder self-neglectors, and they tell her, I only take a bath once a month, but since you were coming, I made it today. And so that's what they do when they go to the physician. And they come clean with a pretty dress and a pocketbook, or they see their nurse practitioner, and you can miss the whole thing. And obviously, we have to remember that we still have to worry about the care of their medical safety needs. Nobody's role changes, but what we're going to talk to you about today is how we can work together to do each of our roles better. I would be drummed out of this place if I didn't say this, and work closely with Adult Protective Services. I think that the state funds this, should I say underfunds this resource. Not anybody here from the legislature, but underfunds this resource. But I think that when you speak to your medical colleagues, your nursing colleagues, these folks can provide you with a lot of information in the field, and they've seen a lot of cases. Consequently, though, like all of us, I don't know, for some of the docs that were here, or some of you that were in training, I mean, you know, you get to a point sometimes where you see things that are so bad. We had a board where we put the very lowest value or the very most abnormal value we saw, and you weren't really cool unless you had like the lowest blood sugar I ever saw was this, was a 9, was the highest calcium. I think that sometimes APS workers see so much of such a bad thing that, I mean, it's just like physicians, you know, we have to try to have a reality check and figure out what in the world is really normal. Here's the problem. Is there documentation in the medical records? Okay, I need people to take a guess here. When we first started to do this work, I went to the medical records in our hospital system, and we are the 4th largest public hospital in the country, Harris County Hospital District, right? How many cases we've got all the ICD-9 codes, and that's how medical folks code these things. How many cases of elder abuse and mistreatment do you think were documented over a 5-year period in the 4th largest public hospital system in the country? 10. I hear 10. What? 40? 20? 5 cases. And my colleagues say the same thing. You know, hey, look, nobody taught us that was even a diagnosis when I was in medical school, when I was in training. I think social work training and nursing training has been much better about it. And I don't know about psychology. Was that something, shaking the head? Dr. Costello shaking his head? No. Where this has really been driven home to me about the medical records is this. We followed suit with San Antonio. San Antonio has a very active, vigorous adult fatality review team where they look at domestic violence cases. And I forgot the name of the physician. He's fabulous. He moved since, but anyway, he sent me his documentation, and we, with a little bit of funding from the American Bar Association, set up an elder abuse fatality review team. We have police officers, protective service workers. We have the DA on there. We have a nurse, a medical examiner. I'm on there. We have a victim's advocate. Anyway, we take a look at the death cases, the suspicious death cases. And I go to the medical records, when we can get them. We go to the medical records, and it's disappointing. There's not the documentation to help the APS workers or the medical examiners make confirmation of what was going on. So, for instance, there was a woman who was, she's not elderly, but she might as well have been 58 years old. 5'8", she was 85 pounds. She was cared for by her husband and her 15-year-old son. She had half of her hair missing on her head. She had decubiti all over her body. In fact, I'm sorry, a little graphic, but at least we're not showing the pictures, but I had never seen vaginal bed sores, pressure ulcers. I've been doing geriatric medicine a long time, and that was really very disturbing. And the case wasn't, the physicians reported that she came in and died of sepsis, but the issue of the suspicion of elder abuse wasn't really raised. Or other times I have seen it where the physicians, or oftentimes because the social worker came and said, look, this, the son or the daughter is not acting right, I think there's a problem, and the physician looks at the case, or they, to their defense, they recognize that it's something, even without any training, they recognize it. And then they write it in the chart, and they say, patient can't get home with family, this and that, and the family comes and says, we'll take care of it, it's all right. They send them back. It's because we don't have the intervention thing done properly. And the cases have been exceedingly hard to prosecute because there's a mention, there's not the clear documentation that's needed. And I don't know, are you going to talk about this a little bit later, or do you want to make a comment now, Judge Hartle?
On
medical documentation.
I was going to talk about documentation and relate it to the case that you and I are testifying in next week.
Oh, okay. Oh, can't wait. Love subpoenas. So anyway, how did we, what approach are we suggesting? It's not rocket science. It's not brain surgery. It's just the right way things should be done. And all of you being in the room here is very affirming to me about that, because you can't do it alone. And so we were very fortunate. You know, we work with the State of Texas Adult Protective Services. We're based at the public hospital, Harris County Hospital District, HCHD, and we have the support of Baylor. And the three organizations together put together this Team Institute, because it became clear we weren't going to be able to, with just one of these organizations, go forward. Now, I remember writing a grant back in, it was one of the first ones I had turned down. Well, they were all turned down until, just the last few years, but anyway. And we wrote about working with Adult Protective Services, and we get these pink sheets back, that they call them, after they evaluate your grant, and it said, Dr. Dyer doesn't know. It's way too hard to work with Adult Protective Services. She overestimates the ability to, and that's one of the reasons why they did not accept the grant. But they didn't know we were working with the State of Texas Adult Protective Services, who have opened their records and allowed us to not only provide the clinical care, but also the research and teach with us. And so without these folks, we couldn't do it. The other thing that's very important about the Harris County Hospital District, and you have a very good hospital district system up here as well, is that if we're going to take Adult Protective Service clients, we're going to be able to care for those who are insured, underinsured, and non-insured. And so we can't do justice by just picking the paying patients. That's a bias of mine. Anyway, this is what our program looks like. GEM stands for Geriatric and Evaluation and Management Unit. We have a house call team. We have a skilled nursing unit. We have a nursing home. We have a clinic. And in the middle, where it says program, we have nurse case management. Everyone in the program has a nurse case manager. And we also have a consult team on the GEM as well. And so this setup looked attractive to Adult Protective Services, and so they joined in on the circle. And so that we can put patients, victims, through these settings, and we have geriatrically trained nurses, social workers, and physicians. But anyway, this is what we arrived at, is that when you think about it, right, these are the personal domains. This is what makes up my life and your life. Right? We have our social networks. We have our functional ability, and what kind of, are we healthy? What's our health? Our medical, are we healthy or not? The problem is that traditional medical approach only looks here. Right? We want to know what your potassium is. I want to know when your last pap smear was. We need to know, do you drink or smoke? And traditional medicine says don't look at the other two. And Adult Protective Services are equipped to look at social and functional side of things. What's the family structure? Can she get into the house with her wheelchair? What about if we looked at all of these things together and did an interdisciplinary approach? By the way, we're working with the National Institute of Health, and when you read their descriptions of their new research, you would think that they discovered teamwork up there in Bethesda at the NIH. They now call it team science. Oh, I know, that sounds impressive. Yeah, I mean, like, corporations have been working in teams for years, really, geriatric nursing. People are working in teams, but it's team science. We were up there in February for a team science conference, and there was a mathematician who came in and showed a scatter plot, a mathematical diagram of how teams work together. And then as the slides progressed, the little dots would come closer and closer and closer, and so we've been saying that for years, and it didn't take any mathematics. Actually, it took HCHD plus APS plus Baylor to do it. And you know what? There's a lot of room around this. This is sort of the basic core Venn diagram, but we need law enforcement, we need the legal system, we need civil attorneys, we need criminal attorneys, we need psychologists, we need any discipline you can think of where they would contribute to the care of older people. And so here's our approach. Again, It's not brain surgery, but it just makes good sense. We generally start out with an assessment by Adult Protective Services and their investigation. I think that's comforting for us because, they've been called out there by the state. They take a look at the situation. They figure out how many guns there are there. They know what it's like. They have done background and spoken to collateral. So then the medical team goes out and we do geriatric assessment. And for the uninitiated, that's where we look at all of the aspects. When you come to our clinic or when we go to your house, we're going to try to figure out not only what your medical care is like, not only what your health is like, but what can you actually do, and what is your social situation like, what's your social support situation, and we call that geriatric assessment. And then lastly, we sit down around a table, sometimes on a phone, and we come up with an interdisciplinary intervention plan. And we make the distinction between interdisciplinary and multidisciplinary. Because multidisciplinary is where people talk to each other, but one person remains decision maker. We do our best to make our decisions through consensus. Here is and I have till 9:20, is that correct? Mm-hmm. Here's the first 9 patients we saw. One of my mentors looked at this and said, "Why didn't you even list their names, Carmel? You had so much detail." But suffice it to say that all of these people, the very first cases, we gave them geriatric assessment, and in 3 months, of all of these 9, the allegation was no longer present. So it gave us just a clue that this approach might be helpful. And I'm going to end with this case that showed that it was. This gentleman was living in a hovel. I went there, Siona came out with me, we were out there with the nurse, so we went out in an interdisciplinary team. It was one of our first cases, and they said, "Oh, now when you drive up, it won't look like anybody lives there," but somebody really does live there. No lock on the door, no tile on the floor, no running water. It's July, and there's a 500-pound man in a bed that's too small for him, and the only clothing he had was a camouflage blanket that he put over himself. He had roaches crawling all over him. The APS worker had been in tears there, the week before. And we talked to him a little bit. He's very guarded. He's